Welcome to the webinar series of Vijaya Diagnostics. Like myself is Dr. D. Srinivasulu, currently working as a consultant radiologist at LB Nagar branch. Okay, and today's webinar topic is like role of CT scan and MRI in the management of diabetic foot. Okay, and our speaker for the day is our senior consultant radiologist, Dr. Vijayanand. Welcome, sir.
Thank you.
Okay, like a few words about our sir. Like sir is a stalwart in the field of MSK, and he has been working for the last 15 years in the field of radiology as well, predominantly in the MSK radiology. His field of interest is mainly MSK. He performs like all the USG CT guided procedures like bone biopsies, vertebral body biopsies, and coming to his degrees, Sir obtained MBBS from MR Medical College, Gulbarga, and did his DMRD from SDU Medical College, Kolar. And further, he did his DNB from the Care Hospitals, Banjara Hills. And after that, he has worked in many corporate hospitals in both Mysore and Hyderabad. So, Sir is both Kannadiga and Telugu, I guess.
Yeah. Thanks, thanks, Dr. Srinivas, by the kind information.
Okay, and sir has many exhibits and publications in both national and international journals. Okay, and sir also added one more feather to his large CV, like by getting a degree from Indian School of Business as well. Okay, in the last November. Okay, sir, let's welcome our chief guest for the day, Dr. Rajasekhar Uyuru garu.
Hello. Hello.
Hello, good
Can
evening,
you hear
sir.
me?
Yes, sir, we are.
Good evening.
Okay.
Can I introduce myself?
Sir, I'll be introducing you.
Because there is something wrong went on the message in information within 30 seconds. I'm Dr. V. Rajasekhar, basically orthopedic surgeon, specialized into foot and ankle, and I have done my research in diabetic foot amputation prevention and leg salvage. Basically, in Hyderabad, I run a center called Safe Steps Daycare Center in Vivekananda Hospital, and I go to Apollo Jubilee Hills also, Health City Jubilee Hills. My aim is to prevent amputations. Thank you.
Okay, like a few things about diabetic foot, like as the obesity has become epidemic nowadays, so and the prevalence of diabetes also has increased. So and this people presenting diabetic patients presenting with ulcer like is almost like 7.5% of the diabetic population. So, sir, in the radiology, when we encounter Charcot neuropathy, we have this mnemonic like 6Ds, which stand for density, destruction, debris, distension, disorganization, dislocation. So now we'll be looking forward to all these Ds in detail by Dr. Vijayanand, sir. So over to you, sir.
Yeah, thank you, Dr. Srinivas, for the kind introduction. And I just want to add few words to Dr. Rajasekhar. I think in February I had a telephonic conversation with Dr. Rajasekhar. That was the first time I had an interaction, and he looked so humble and down to earth. I did not, but I only knew about him that he's a legend in his field. When I met him during one of my talks, and I think today's uh, webinar will definitely we'll all be gaining a lot of knowledge from his uh, huge experience. I have not only, I think, India, I think from abroad also, I saw many people coming and appreciating his work. Okay, so welcome on board once again from Vijaya
Thank
Diagnostic.
you. Thanks for your kind words. Let's carry on.
Yeah, sir. So
Thank you.
yeah, so I'll be starting. I think everyone is seeing my screen. Dr. Srinivas, are you seeing that my
We are
screen?
able to see your screen. So just go to the next
Okay.
slide if it's working.
Yeah. Okay. So
Okay.
what I
We
will
are
be
seeing
doing is like before I go into the territory of Dr. Rajasekhar, which is the treatment part, management part, and helping him diagnosing. I'll just limit myself to the normal anatomy of foot on CT and MRI. How does it look? Okay, then I'll be going into the radiology and pathology, post which we can give it to Rajasekhar sir, how he goes about that. So, coming to the anatomy on the basically the CT anatomy, what you can, I think you can see three pictures on the screen here. First one is the coronal image. There is some background noise. Can someone please mute that?
Rajshekhar sir muted. Okay.
Yeah. Okay. Thank you. So this is the coronal CT scan. Normally, what CT does is it takes multiple slice of the foot. So what you're seeing, the first image, you're seeing this arrow. I guess your people are seeing the arrow.
So we are able to see the arrow.
Yeah. What happens is we cannot see all the bones in a single slice. It is basically act of multiple slices through which we generate the CT scan. Like what we have generated, the last image, what you are seeing is the 3D reconstruction of the foot. So to see foot in one slice, it's not possible. So this is one of the representative section wherein you are able to see maximum number of the bones. This is just for showing. Okay. What you are seeing here, you are seeing multiple uh, tarsal bones and four metatarsal bones, and you are seeing few phalanges. And you can also see that there are all these metatarsal joints, metatarsophalangeal joints, and intertarsal joints, which are seen very clearly. The margins are very smooth, and the soft tissue around these bones is also very clear. And this is the sagittal, wherein you are seeing this is the tibia and this is talus calcaneum, tibiotalar joint, talocalcaneal joint, then talonavicular joint, and first tarso metatarsal joint. Okay, what you are seeing here in this is it's a normal foot with a normal joint spaces, normal soft tissue around it. And this is a 3D reconstruction of multiple slices what we have done, and we are appreciating the foot. However, we are not able to see the posterior part of the heel part, calcaneal part of this thing, because it's not in a rotational mode. Okay, this is how CT looks. X-ray and CT basically are almost similar, but there is some advantage of CT scan over the X-ray, because it provides excellent low contrast resolution, and it also helps in improving the diagnostic interpretation of the images by showing the better bone density, the trabecular pattern. You can see the trabecular pattern within the bones very clearly. Then the margins, as I told you, the margins are very smooth and crisp. And you can also see the joint spaces, which are very clear. And you can see the soft tissue. This is additional finding wherein you can see the soft tissue and the vascular calcifications better compared to the X-rays. This is again the normal foot MRI. Again, this is again MRI is again we all know is a multiplanar modality wherein you have to see in three different planes. This is the coronal plane where you can see like CT scan. Again, it's not we will not be able to see all the bones in a single stretch, though we are seeing most of them. And here, this is the stir or the fat sensitive sequence, and this is the T1 image of forefoot and midfoot area. This is showing the great toe with the interphalangeal joints and metatarsophalangeal joint. And this is the axial image taken at the level of the midfoot or anterior or posterior forefoot, you can tell, wherein you can see all these metatarsal heads, and then you can see all the muscles very clearly. Okay, this is one of the section which helps us in seeing the extension from to the dorsal surface of the foot. Okay, and this is the axial representation of the foot. They're taken at one level. This is the T1, and this is the stir sequence wherein you are able to see the whole length of foot from tip of the toe to the heel or the calcaneum. Here also, you can see the bones. Basically, MRI is known for its great help in identifying or diagnosing the narrow tissue and narrow abnormalities. So basically, it helps in the soft interpretation and also the marrow edema, because marrow edema most of the times you cannot see either in X-rays or CT scan. So this is one of the excellent modality and the modality of choice you can tell, wherein you can identify the subtle marrow issues. And also other than that, you can also see the cartilages very clearly. You can see this between the first metatarsal and uh, proximal phalanx. You can see these cartilages. The article cartilages are very, very clear. There are no erosions, no joint effusion, and you can see the margins, the periosteum of these bones. Everything is crystal clear and very crisp. Okay. So basically, how does MRI help? It helps in improving the diagnostic interpretation by looking at the marrow, giving the information of the marrow, and also muscles, ligaments, tendons, and any occult joint space details. So, very small, brief pathophysiology of how this diabetic foot happens before I go into the pathology of the uh, diabetic foot. What happens is most of the people who are having high blood sugar level, they have they gradual it's a gradual process wherein it damages the nerves and blood vessels, and that leads to diabetic neuropathy. Again, that leads to numbness, tingling of the foot, and there is also pain or sensory loss. Because there is a loss of sensory loss, what happens is they may injure the leg and they won't feel the pain, and the person can have a cut or a blister or a ulcer, which further will get infected, and this infection will not heal because of the damaged blood vessels, because of the poor flow into the foot. This is when now most of the patients come to the doctor. Then they think it's a very benign process, or they ignore it. It's terrible. They come to the doctor, and here this clinician's work starts. Basically, because of having the infection and poor blood flow, the changes of gangrene start happening, and this gangrene or foot ulcer that does not get better with the treatment, and ultimately may lead to amputation. And this decision whether the person needs an amputation or does not need an amputation, those will be taken after having the investigation and then clinically correlating with that, and uh, going ahead to save the life of the patient, because without amputation sometimes saving the life of the patient can be difficult. So, what are the complications that can happen in case of diabetic foot? Here, I will just tell you exactly what are the few complications that can happen, and then how does it look clinically, where it is most affected, and what is the role of the X-ray, CT, and MRI at these stages. Firstly, this is picture what you're seeing is the osteomyelitis part, where you're seeing a marker wherein you see an ulcer, you see a small sinus tract entering up to the heel or the calcaneum bone, and you can see a bright spot which is the marrow edema or infection of the foot. This is basically osteomyelitis. Here, clinically, it looks like a hot red foot with ulcer. This may occur either in the foot, or it may occur like a hind foot or forefoot region. Okay, and on X-ray, in the initial phases, maybe first few weeks, it is normal. Even on the CT scan also, it can be normal. Other than the ulcer part or soft tissue subtle edema part, you may not be able to identify the marrow edema part of the calcaneum or any other part of the bones. But MRI plays a very vital role here. It helps in giving the information about the marrow edema wherever, whichever bone is involved. So we understand that there is a ulcer, there is a fistulous tract, and then there is infection happening in the bone, so which is osteomyelitis. Charcot's disease. This is again actually a very hidden thing, because clinically, by the look of it, it looks like a hot red foot, but there is no ulcer. Okay, it can occur where in the midfoot or in the midfoot. Most of the times it occurs in midfoot, and it occurs in the subarticular region where you are seeing these white areas. Okay. Again, X-ray and CT scan will not give much of information in this stage, because you're not able to see any ulcer, you're not able to see any bony destruction, you're not able to see the misalignment of the bony structures. But if you do an MRI at this stage, you may find marrow edema in the midfoot in this involved area. Coming to the next is a chronic Charcot, wherein foot is swollen. It's basically a swollen neuropathic foot, but there may not be having any ulcer. because this progresses to chronic charcot. And then you can see the joint deformity, dislocation, and rocker bottom foot, or basically the misaligned, or there is dislocations of all the foot bones, okay, leading to rocker bottom foot. However, there is no marrow edema in this, but at this stage we don't even need MRI, because most of the things are either appreciated better on X-ray or CT scan. Okay, so not much of role here, but it can definitely give other information, which I'll be showing during my MRI slides. Then this is a superimposed infection, okay, wherein again you see hot red foot with ulcer or sinus tract, and you have all these joint deformity, dislocation, rocker bottom foot, everything. And MRI again here shows marrow edema. Here it is showing in the cuboidal bone with the ulcer is there, and there is also tract, and there is also osteomyelitis of the bone. So basically, we need to understand that X-ray or CT scan may be, unless and until the person is an expert, it may be difficult for the inexperienced eyes to pick the findings, especially the early osteomyelitis or active Charcot's disease. Okay, but MRI will help us in giving information in all these stages. So whenever there is a requisition from the clinicians that they are suspecting these things, we need to be uh, very like do the what do you see this clear this, we should see it with the eagle's eyes and try to look for the subtle findings, unless and until we don't do MRI. Once we do MRI, it's basically clear. So, as already Dr. Srinivas was mentioning about the Charcot's disease, the 5Ds, what is well known across the world and to the clinicians, radiologists, and any other physicians, everyone. Uh, what is these 5D? Basically, the Charcot's 5Ds are distension of the joints. This is a classical X-ray wherein you can see all the features. That's the reason I put this picture. Basically is an X-ray. I'll be showing the CT scan in the next slide. Okay, so distension of the joint. You can see there is distension of the joint at few places. There is destruction of the bones. There is no margins at all seen in the tarsal bones, in most of the tarsal bones, and also the base of the metatarsal bones. Then you can see it is disorganized, totally disorganized. It does not have any alignment, and it is also dislocated. And other than that, you can also see the debris. You can see you can see these areas of hyperdense or dense areas within the joints, small soft tissue dense areas, swelling area, some soft tissue density here. These are all the debris. It can be calcified or non-calcified, either loose bodies or some debris or pus or some other things that can be seen. Next is the increased density or sclerosis. Basically, what happens is during the course of Charcot's disease, there will be sclerosis, destruction. There will be destruction, and then there will be some amount of healing which comes with the sclerosis. And you can see few areas of sclerotic margins here in this tarsal bone. And these can be again better seen in the CT scan also, which I'll be showing in the next slide. Okay, this is a CT scan of a diabetic foot here. What you can see, basically, first what thing you need to appreciate is the osteopenia. Basically, you can see osteopenia is seen in most of the bones, or periarticular osteopenia. What do you call? But then, whenever there is infection, we find that here, what you can see, there is decreased joint spacing. What I said in the very first slide, where the joint space is very clear. You're not able to appreciate that the joint space are reduced. You are seeing small subchondral erosions seen at the base of the metatarsal joints. Also in the intertarsal joints, you can see small erosions, and there is loss of joint space. There is multiple small calcifications or loose bodies around the joint. There is periosteal reaction. If you can see here, this bone is showing a periosteal reaction, and you can also see some amount of sclerosis in some of the bones. You can see this part of this bone. This bone shows navicular bone, I guess so. It shows sclerosis. This is also this part, this bone also, you can see this image also shows similar picture. And here you can see again in debris, there is some amount of speculations or widening of the first base of the first or base of the terminal phalanx with the osteophyte formation, and also loose body. Okay, so this clarity is slightly more in case of CT scan because of the three-dimensional or the multi-parametric approach. However, see, X-rays also give maximum information to the experienced eyes. I don't have any other this thing because many people what I can see on CT scan or what I can see on X-ray, the person who's experienced can see those things on what I can see on CT that the experienced person can see on X-ray also. So it depends from person to person, but for general population or general clinicians who are not very much experienced into looking at the images, CT actually gives slightly more edge because the information provided is slightly better. And again, this is another example wherein you can see the sclerosis, periosteal reaction, widening of the joint, dislocation or dislocations, and you can see the rocker bottom foot wherein the whole of the angulation of this tarsal and the talar and the other tarsal bones are angulating almost down, almost 180-degree down, and causing the rocker bottom foot. Here you can see small loose bodies, soft tissue, widening, then dislocation. Okay. This is another example. Other than all the points I explained, what you can see here is a small lytic area and then a small sequestrum, which suggests uh, it is a case of osteomyelitis. Okay, so this is one of the additional features which CTs can give uh, in the case of overlapping bones. Sometimes these subtle findings can be missed, but anyway, if you can see that there is some pus discharge continuously, we can always see on the X-ray also. But this is one of the pictures showing clear-cut lytic area with a small sequestrum within it, and you can see this cuboid bone is almost completely coming down and pressing the plantar fascia inferiorly, suggesting it's a rocker bottom foot. This is X-ray showing a normal foot. You can see the plantar arch very beautifully here. But this is a case of X-ray showing, you can see the angulation. This is a straight line, and this is the angulated obtuse superiorly. It means that all the tarsal bones are angulating downwards, forming a obtuse angle superiorly, which is called as a rocker bottom foot. This is the again pictorial representation of the 3D representation foot showing the Charcot's foot. Coming to MRI, I'll be explaining in slightly detail because some of the clinicians friends may be listening to this, and it may be difficult if I try to go a little fast in this case. What we can see here, this is a small field of view. I am just taking a sagittal section of the foot taken at the level of the midfoot. And what you can see here, this is the stir sequence, this is the T1 sequence, and this is the T1 contrast study. And all taken at the same level. This stir, what red arrow you are seeing is the small defect along the plantar surface of the foot. And what you can see is there is a small tract which you are not able to appreciate here, but you can see there is an abscess, well-defined abscess in the forefoot region in the intramuscular planes. And you can also see diffuse soft tissue edema around it. Coming to the T1, though the clarity is not very clear, but you are seeing the edema part, and you are seeing diffuse hypointense signals, and you are able to see the a very faint abscess-like thing, which is slightly different. But the reason why we have done this was because we need to show it on contrast how this enhances, and that will be one of the additional findings or helping finding that will add to the diagnosis. What we are seeing here is again the defect. You can give a sinus tract, and there's an abscess over here, and this abscess is showing a rim enhancement. Okay, and around this you can also see there is diffuse enhancement of the granulation tissue around the abscess. You want the same thing. This is actually what you can see the T1 you're seeing as a black or the hypointense area. Everything is showing enhancement. Basically, this is the enhancement of the uh, wait, I'm thinking. Yeah, this was done. Okay, this is another case of diabetic foot, wherein you can see it's a case of Charcot's neuroarthropathy with a plantar ulcer, okay, and osteomyelitis of the bone. I'll just show you all the features. How does that look? This is a small skin defect or the ulcer over the plantar aspect of the midfoot, and you can see a small heterogeneous area in the plantar surface, and you can see a small sinus tract. Basically, you're not able to appreciate in this, but in the next slide, next picture, I'll show you, and you can see edema in the cuboid bone. Edema is the white part in the cuboid bone. You can compare it with the other normal part of the bones. This is a white thing. This is the edematous or marrow edema of the bone, which suggests that there is some infection going on. And you can also see some soft tissue edema around it in the plantar surface. Okay, this is the T1, just to show for the post-contrast study, wherein you can see the ulcer, and you can also see there is soft tissue edema along the plantar surface and small area of marrow edema. Okay, on contrast study, what you can see, the sinus tract, which you are not able to see there from the base of the from the ulcer, you can see there is a small irregular area like a sinus tract going almost to the cuboid bone. This is basically the enhancement of the wall of the ulcer as well as the granulation tissue, and you can also see a small irregular area of necrotic bone, which is not enhancing, and other part of the bone or cuboid bone shows faint enhancement. Okay, and on T1 fat sat or the same post gadolinium or post contrast, we do T1 fat sat also, wherein that shows better appreciation of the areas of enhancement in the bone as well as the soft tissue. Okay, so this is the T1 gadolinium post contrast study, and this T1 contrast is one of the sequences we need to delineate the ulcer walls very properly, and also the areas of necrosis of the bones, which otherwise we will not be able to see properly, because you're not able to see in any other part. Take it as a stir or T1 or maybe this one, because in the T1 fat set also, because the edema is too much. Whereas in this post contrast, you can be able to see the necrotic part of the cuboid bone. Okay, this is another example. Another type of example in the diabetic foot, wherein you can see ulcer along the plantar surface of the foot, and you can see diffuse edema along the plantar surface in the midfoot, forefoot, and also along the intermuscular planes of the dorsum of the foot. We can see there is diffuse edema, but however, if you can see, this is post-contrast study, wherein you can see this sinus tract going from the plantar, from the ulcer to the bone, but there is no marrow edema involving the cuboid bone or any other midfoot bones that can get affected, suggesting that there is no evidence of any osteomyelitis in this case. However, there is an ulcer and then all inflammation and infection going around the in and around the bones, but there is no involvement of the bone. So this is one of the important study, wherein a post-contrast study, which helps us in identifying that osteomyelitis is present or no. This is ghost sign. Now, what is ghost sign? Again, this is a T1 study, wherein you can see a small irregular wedge-shaped or triangle-shaped defect in the posterior aspect of the calcaneum, and you can see an ulcer along the heel or along the sole. Then you can see a small irregular tract going up to the level of the bone. But on contrast study, what you saw, it an aggressive black or the marrow edema part, marrow edema like area was seen around this, almost occupying 2/3 of the calcaneum, is not appreciated in the post contrast study. Basically, it has become invisible suddenly because of the contrast enhancement, suggesting that it looks almost normal on contrast study. But the main bone which was affected, that is the necrotic bone, you can see it's very well defined margins and as a necrotic non-enhancing part, whereas the rest of this part is enhancing like a normal bone. Okay, so basically this is called ghost sign because what was seen as an aggressive part or aggressive area in the calcaneum was not visible here in the post-contrast study, suggesting that that the poor definition margins of this T1 weighted images become clear after contrast administration. Okay, so the osteomyelitis part can always be better appreciated on T1 contrast study. That is the take-home point for this ghost sign. So what are the differential diagnoses for the diabetic foot? First and the most important is septic arthritis. Though I told that is a progressive, very slow lesion. Septic arthritis is one of the arthritis which is very destructive and very rapidly grows, and that can always, or like sometimes can also lead to death. Okay, so we need to be very precise in diagnosing the septic arthritis, because the every day the arthritis, I mean the septic arthritis can progress every day to at a very fast pace. So we need to be very proactive in identifying the septic arthritis. Next is cellulitis. Basically, it is the inflammation of the subcutaneous plane and dermis part. Okay, again, patient MRI. If you are doing an MRI or something, you can identify the edema part, erythema part, and here and there patchy edema part in the subcutaneous tissue, as well as also sometimes in the bones. But then we need to understand and diagnose it properly and give based upon the history and the clinical history what we are getting from the clinician. Next is infectious myositis. It is again an infection of the skeletal muscle that can be acute, subacute, or chronic. Okay, and then pyomyositis is one of the again specific part wherein there is infection and pus formation in the skeletal muscle. Okay, this again is a very fast, very aggressive infection. So always better to take good care of that. Then necrotizing fasciitis is also another again life-threatening condition. It refers to rapidly progressive and often fatal aggressive necrotizing soft tissue infection, and it spreads hematogeneously and can cause death. And Sappho syndrome is an acronym that refers to a rare syndrome manifested by synovitis, then acne, pustulosis, hyperostosis, and osteitis. Now, why these differential diagnoses is basically sometimes if we are not able to get the history from the clinician, everything looks same for us. So this is basically a radiological differential diagnosis. Maybe some differential diagnosis may be added or deleted based upon the clinic once we get the clinical history from the clinicians. This is what the differential diagnoses are listed in the book radiologically. So what are the key takeaways from today's presentation are the arterial calcifications, soft tissue ulcerations, Charcot joints, and osteomyelitis are the most important points to look for in case of diabetic foot. Okay, and CT scan gives better information of the bony details, soft tissue and vascular calcifications. It can also pick up these subtle bony findings like periosteal reaction, osteophytes, and subchondral small erosions or lysis. And MRI is the investigation of choice, not only in establishing the early diagnosis, but also helps in monitoring and also helps in the progression of the disease activity, and also to give the leading complications. So basically, it is a silent killer wherein you can see that we feel that this is a benign. We feel that a small ulcer sitting on the foot is like a benign cat sitting just looking towards our foot. But if we keep on delaying the treatment or ignore it, we may lose our foot because it may bite off and it may leads to amputation. Okay, thanks for the patient listening. I'm really sorry because my voice was inaudible in between.
No issues. It was just for one slide, sir. We didn't miss much.
Sir.
Okay, sir. It was a wonderful presentation, and the last slide was the clear depiction of the Charcot's joint. So it was nice presentation, sir.
Yeah, thank you.
Sir, I have a small doubt. Like, is contrast really necessary in all the cases?
Whenever there is a doubt, because if we see a small areas of heterogeneous area, which we feel that this can be a osteomyelitis, because osteomyelitis sometimes can be really subtle.
Yes.
Those stir or the stirs or the fluid sensitive sequences, any sequences can give us information. But as I told you, if there is a marrow edema, within the marrow edema, a small triangle shape or wedge shape or subtle finding along the base or subchondral region, we need to identify whether it is a erosion or whether it is a destruction or whether it is an osteomyelitis. So in that case, it may be needed.
Okay, sir. Sir, to Raja, sir, like, are you able to hear us, sir?
Yes. Can you hear me? Hello.
Yes, yes.
It's an excellent presentation in a nutshell. It's exemplary. In a half an hour time, we have tried to explain everything about Charcos. I have a few suggestions to my fellow doctors, radiologists, if you can.
Sure.
Let us share the experiences.
Yes,
Number one, many radiologists who, when they give the report, either CT or MRI, they don't mention can be a neuropathic joint. That's one thing. Second thing, why I am telling this is, many of my patients, when they come, already it's a late stage. As you know, Charcos in the heart stage, if we can make the patient non-weight bearing, the damage can be minimized. That is our golden period for 6 weeks to 8 weeks. But first 6 to 8 weeks, they take 3-4 courses of IV antibiotics, oral antibiotics. Everybody thinks it is a cellulitis, and by the time they come to me, already the damage starts. What are the findings in the bone starts, destruction, and the shape outs. So initial stage, heart stage, is very important for a clinician to ring to the radiologist and discuss about the case. The coordination is very important. That can save the feet. That's what I observed, one thing. Right. Second thing, I will tell one of my experiences that reflects how much is important is CT or MRI. Not just normal X-ray is not enough. I got one patient with cellulitis, and he was given 2-3 times incisions and pus drainage. Then I sent the patient for the MRI. MRI clearly denotes Vijaya Diagnostics MRI only. It's clearly, the report mentions there is a synovial sheet inflammation, and along the tendon they can see the altered signal of great flexors of the great toe, long flexors of the great toe. Then I opened the sole again. I went along the tendon up to medial malleolar region, up to tarsal tunnel, and released the synovial sheet from the tendon, and I removed the pus, and patient is fine. So how can you get it in the normal X-ray?
True.
A surgeon is doing the incision, drainage of the pus, again it is recurring. Unless the source of infection along the tendon, you go up to the musculoskeletal, musculotendinous junction, the infection cannot be eradicated. So this is the such an importance MRI is having, one thing. And other thing is, Dr. Vijayanand should answer my question now.
Yeah, yes, sir.
How early? See, suppose a conventional X-ray, we see we declare osteomyelitis when there is a periosteal reaction. Am I right?
Yes.
So how early we can diagnose in a MRI or CT? Which is better? How early we diagnose? Tell us, please.
As early as the patient comes with the complaint, sir. The moment the patient comes with a complaint.
Yeah, osteomyelitis. How early we can diagnose?
The moment the patient feels pain or whatever it is, any clinical symptoms that you feel that it looks like it can be diabetic foot or Charcot joint, whatever it is, the day the patient comes to us, we can tell it is injured. MRI can pick the lesion very at the earliest point, sir. At the earliest point, the marrow edema part I'm talking about. But then, if there is clinical history which is matching,
marrow edema,
a comprehensive diagnosis. But picking what happens here is, if the clinician and the radiologist together they are interacting, then we can come to a single point diagnosis. Otherwise, what happens is, if there is no interaction and there is no suggestion from the clinician that I am suspecting this, then what happens is the doctor goes blindly, radiologist goes blindly. There are, like as I told you, 5-6 differential diagnoses. We'll put one among them there and then leave it. So what I suggest is, if you feel that's what. So
carry on, please.
If you suspect, any clinician for that matter suspects and just give us a clue or write it in his prescription, I think 90% of the reports will be will help the patients only.
And one more thing, the 3D reconstruction of the CT foot is really, really helpful in designing and planning my osteotomy to correct the foot deformity. Nowadays, we are in Apollo, we are doing Charcot's reconstructions. Dr. Venu comes from King's College, London University, once in 3 months. So we made almost 3D reconstruction, sometimes the physical model. Physical model really helps after the 3D reconstruction, whatever you do report on the CT. We are doing the physical model, some of the cases. It's really helpful, and it improves our accuracy doing the surgery. It's very good.
So just you can just write a prescription that this thing, CT scan of foot with 3D recon. It doesn't take much time of us. It's just a matter of you can always give.
And I have learned a new thing today: ghost side.
Yeah.
so there is a use of contrast in the osteomyelitis cases. Okay, right.
The moment you give the contrast, it looks like the ghost disappears. It's like what you call Hanuman Chalisa. Suddenly the ghost disappears. It acts like a contrast, acts like Hanuman Chalisa.
Okay.
Yes,
Sir, to Raja sir.
Yeah.
Like almost daily in our ultrasound practice, like we get a case of cellulitis, the Doppler, sir. On most of the days we get them. Like, are there any clinical clues to like suspect that there is underlying Charcot's? Because like, do we have any signs like to suspect Charcot's clinically other than the redness? Like when
Charcot's, see, this is like whatever blindly I follow. If there is a foot, you are suspecting the Charcot's. If that foot is insensitive or sensitive. If it is an insensitive feet, just go for that. Until you get the final diagnosis, you think it is Charcot's. And well, under ultrasound guidance, sometimes I used to do needle aspiration. Needle aspiration to check it is a septic arthritis or only Charcot's and send that fluid. All this we have done. All this we have done. But one thing is first insensitive foot, then shape of the foot is changing. Compared to cellulitis, the flattening of the arch happens very fast in acute Charcot's. Then we see the temperature difference. Of course, even in infection cases, temperature rises. But in acute Charcot's, it rises so much. And typically, the symptom from the patient is painful or painless. Okay. Painful or painless. If it is painful, go for septic arthritis under a musculoskeletal ultrasound guidance. Put your white bore needle. You are going to get it. Here or there, you can see the joint. Otherwise, I take it as granted as Charcot's. As a benefit of doubt, I immobilize in a plaster slab and ask them not to bear weight. Either it is a septic arthritis or a Charcot's. If they bear weight, cartilage is going to get damaged even in septic arthritis. Or some clinicians say the infection can ascend up. Some clinicians say infection can ascend up. So immobilization, non-weight bearing is the golden points. Golden principles I found. With this, thank you very much. I have a train to catch. Thank you very much for inviting me as a chief guest. It's an honor for me, Dr. Vijayanand's words. It's an honor from an organization that is India's biggest investigations diagnostics chain. I'm honored. Thank you very much. Once again, congratulations, Dr. Vijayanand. We'll meet like this on webinars frequently. Thank you very much. Thanks, Dr. Srinivasulu and all audience. Bye.
Sir, thanks for your valuable time. Thank you, sir.
Thank you, Srini.
Sir, I would like to thank Krishnamohan sir for giving me this opportunity, and thank Vijayanand sir. Okay, sir.
Yeah. It was
Have
nice.
a nice day. Have a nice weekend, sir.